connection interruption or low or no sound or video freezing, video lag, kindly leave the meeting and rejoin with the same link. And again, check your internet connection. Please answer the poll questions, if any, by typing in the chat box. Please do not send requests for annotation to the presenters. Okay, and here are the few upcoming talks. On December 17th, we have Approach to Soft Tissue Tumors by Dr. Praveen Mahajan. And on 19th December, we have a slide seminar of lung and mediastinal lesions by Dr. Rajiv and Dr. Trupti. A few disclaimers. And today's session, we have a couple of postgraduates. I would like all of them to give a very brief introduction before we start the session. Dr. Bhavana.
Good evening, everybody. I'm Dr. Bhavana from D.R. Patil Medical College, Navi Mumbai.
Okay. And then Dr. Janabi.
Good evening, everyone. I am Dr. Janavi Saikia from Assam Medical College, Dibrugarh.
Then we have Dr. Nikita.
Good evening, everybody. I am Dr. Nikita from IGMC Shimla.
Then we have Dr. Lokeshwaran.
I am Dr. Lokeshwaran, first year postgraduate from Gandhi Medical College, Hyderabad.
Okay, we have Dr. Ajay.
Good evening, everyone. Myself, Dr. Ajay from Dr. BMGMC, Solapur, Maharashtra.
Then we have Dr. Mahima.
Good evening, everyone. I am Dr. Mahima from Royalkan Medical College, Bareilly.
And the last postgraduate is Dr. Atreyi.
Good evening, everyone. This is Dr. Atreyi Chakraborty, junior resident from IMS PhD.
Okay, so let us say, all eagerly waiting for you, ma'am. So today's skin biopsy interpretation.
Would you like Dr. Sridhar to say something?
Excuse me.
Hi, Uma, you starting?
Yes,
Sharing
sir.
the screen, Uma?
Yeah, I'm doing that.
Yeah.
Faculty is Dr. Majri at PGIMER Chandigarh. He gets ready with the slides. She is an experienced dermatopathologist, and she will walk us through the basics of. Over to Dr. Umana.
Thank you, Dr. Sridhar. So, is my screen visible?
Yes, ma'am.
Okay.
Yes,
am I audible?
Yes, ma'am.
Okay, right. So, what is this pattern in the first slide? This picture. What does it say?
Okay.
What does it say? What is it written here?
PGI.
PGI.
Yeah. So you know it is PGI because you know the alphabet P, G, and I. So this is what I'm going to do today. I'm just going to give you an overview of the patterns, the normal morphology of the skin biopsy interpretation. So you will see things only when your mind knows about it, right? Because you are aware about these alphabets, you could identify it. Okay. Now, just going back to the history, the term dermatopathology was coined way back in 1792. And that was dermatopathologist Julius and Rosenbaum in 1844. You'd imagine the dermatopathology was coined so long ago, right? However, it was Dr. Eckermann, Bernard Eckermann from USA, who actually coined these terminologies for dermatologists as well as dermatopathologists, so that we have a single platform to communicate with each other. Otherwise, the dermatologists say something else and the pathologists say something else. Okay. Now, to introduce, the skin is just the largest organ. We all know that. And it comprises mainly of two layers, the epidermis and the dermis. And along with that, you have subcutaneous adipose tissue, also called as hypodermis. But hypodermis is not considered as part of skin, right? So skin, when we talk of, we are only restricted to epidermis and dermis. However, when there is involvement of hypodermis, we need to biopsy that as well. If you see here, there's a thick layer of keratin in the epidermis. You have this epidermal layer, the dermis. The papillary dermis is this one, which is in between these retipex. These elongated structures which are dipping into the dermis, they are called retipex. And in between these retipex are the papillary dermis. And just beneath is the reticular dermis. Okay. And this is the hypodermal region and the dermohypodermal junction. And here lies mostly the nerves and vascular structure. So if you need to look at the vascular pathology or neural pathology, you look at this area. Now let's look at the skin on a closer look. So you see the stratum corneum is an acellular proteinaceous keratin material followed by granular layer, and the granular layer usually is 2 to 4, max to max 5 in number, and this has blue keratohyaline granules. That's why it's called as granular layer, followed by a thick layer of keratinocytes, which is also called as stratum spinosum. So why spinosum? Because these are connected to each other by the spiny processes, okay, which are the desmosomes. And then, of course, you have the last layer, that is the basal layer, which is forming a picket fence-like appearance, and in between the basal layer, you have these melanocytes. So if you count the cells, the keratinocytes comprise of almost 90% of the epidermal thickness, right? And the most prominently, it is the stratum spinosum, followed by melanocytes, some Langerhans cells, and occasional Merkel cells in the epidermis. Now let's look at the keratinocytes closely. They have round to oval nuclei, and they are connected to each other by desmosomes, right? And when we do IHC, they'll be positive for CK56 and P63. And if you perform an electron microscopy, you will see these desmosomes like this. This is one keratinocyte. These are the desmosome, and this is the another keratinocyte, which is, I'm sorry, something happened. I'm so sorry. I have to share again. Sorry. I did that hide thing and then everything went off. Okay, is it visible now?
Yes, ma'am.
Hello? Yeah.
Yes,
So
ma'am.
if you see this picture also, this is your epidermis, the keratin layer, and these are all the desmosomes. Okay, and some blackish round things are the pigment, that is the melanosomes containing the melanocytes containing melanosomes. Now there are certain clear cells within the epidermis, and what are they? So in the basal layer there are melanocytes. In the stratum spinosum, there are Langerhans cells, and rarely you can find Merkel cells. And in the epidermis of the nipple area, you find the Toker cells. Okay, you need to know these variations in the skin of all body parts, because when the pathology occurs, these are the cells which are involved in any pathology. Now let's come to the first cell, that is melanocytes. So this is the normal epidermis, the basket weave appearance of the keratin. This is the normal appearance of the keratin. So this is basket weave appearance, and melanocytes are interspersed between the basal layer. And in Asian skin, it is around 15 to 20 basal cells with one melanocytes, and melanocytes have a clear halo around them, as pointed by this arrow, right? See here, and this is a so-called relatively normal epidermis for an Asian skin. This is moderately pigmented skin where you have increased number of melanocytes, and this is the darkly pigmented skin where you have more number of melanocytes containing this melanin pigment. And if you do an ultrastructural examination, these are the melanosomes containing melanin pigment. These dark color things are the melanin pigment within the melanosomes, melanocytes. Okay. Now, Langerhans cells, we all know there's an antigen presenting cell. Normally, it is very difficult to visualize it. However, if you closely see it, they're also surrounded by halo, but they'll be seen in the stratum spinosum, not in the basal layer. Melanocytes will be present in the basal layer, whereas stratum spinosum will show you Langerhans cells, and they can be very well delineated by IHC as seen here. They have these dendritic processes. So you can do CD1A or Langerhans IHC, and if you do electron microscopy, you will find this racket and tennis appearance, tennis racket appearance of the Langerhans cell, a characteristic hallmark feature of Langerhans cells. And they are present when they are increased in number and they're too much, then you have a disease called Langerhans cell histiocytosis. Okay. Now let's come to the Merkel cells, which are the mechanoreceptors, mostly more prominently seen in the palms and soles. And they usually could not be visualized on the normal H&E. Now this is a tall blue stain. This is an ultra thin section of an epidermis, and you can see these metachromatic granules in the Merkel cells. And electron microscopy, you will have these like dense core granules. Now someone might say, that the melanocytes and these look same. But if you see closely, let's go back to the melanocytes. These are very dark, ovoid to round, whereas these are less dense and they are surrounded by a membrane. So these are the dense core granules, and the tumor which arises from these is Merkel cell carcinoma. Okay. Now,
Dr. Umar, can I interject?
Sure, Dr. Sridhar.
How I teach my first year residents is the Merkel cell is similar in shape to the keratinocyte. The Langerhans cell is similar in shape to the melanocyte. The reason is the melanocyte has got dendritic processes. The Langerhans cell also has
melanocytes will not have dendritic processes.
the melanocytes do have.
Sorry to interrupt you. Dendritic processes will be seen in the Langerhans cell. So let me go back to the, see here, the Langerhans cells are seen in the stratum spinosum. They're little oval and they are also surrounded by halo, and IHC will show their dendritic processes. Whereas the melanocytes are more round, again halo, but they are interspersed in the basal layer. Okay. And if you see ultrastructural examination, this is how it looks. So problem occurs when there is melanoma or when there is increased pigmentation. Sometimes the melanocyte is not increased, but the pigmentation is increased in the skin, especially post-inflammatory pigmentation or some other cause of pigmentation. So there is only increase in pigment, but not increase in the melanocytic number. That is only seen in the darkly pigmented skin, or the particular skin areas like anogenital or vulval region or axillary region, where you will have relative increased number of melanocytes with increased pigment. Whereas otherwise in Asian skin, it is around 15 to 20 melanocytes per basal cells. Okay, so dendritic processes, actually not dendritic processes. If you talk about this spinosum, you have these little spaces, thin spaces, if you see, as if someone has drawn an outline around these keratinocytes. So this is because of the desmosomes. Melanocytes will not show you any attachment. That's why the melanoma will not have any clustering. These are epithelial cells, right? These are the keratinized cells, and melanocytes will be having tumor which will have nodules or sheaths because they do not have attachment to the surroundings. So is Langerhans cells. If you see Langerhans, they will have dendritic processes within the epidermis. You see here. And they are the antigen presenting cells. So when you look at LCH, the infiltrate is going to be here in the subepidermal region and going up again. So the lesion starts here and it involves the dermis as well as superficial epidermis. Okay. Anybody, any doubt in this? This is very important to know. When you know the right location of the cells, only then you can understand the pathology better. So did you understand about the melanocyte, Langerhans cell and Merkel cell? And Merkel cell is very difficult to visualize on HNE. You will have to do either ultrastructural examination or a thin tall blue stain where you can see this metachromatic magenta colored granules around them. Okay. Anybody? So I think all clear.
Yeah, ma'am.
So Dr. Sridhar. Yeah, okay. So now the next structure is the acrosyringium. Many times when you get a skin biopsy, you get to see these ducts, right? See this. This is the intraepidermal part of the shaft of the hair follicle, right? So which runs through the epidermis and it opens up on the epidermis. And this is what we call it as follicular plugging, right? So this is called, the tumor which arises from this is oroma because it has a ductal differentiation. If you closely see, this has a vague ductal differentiation which you have to notice, which you have to look at carefully. It will not be visible on low power. See, and next to it, even in here, you can see some melanocytes seen here. Okay, next to it, see here. Okay, melanin pigment is also there in these melanocytes, this brownish pigment. Fine. Okay. Then, of course, once you know the cells of the epidermis, the basement membrane is seen. So basement membrane usually is not this prominent. This is relatively thickened basement membrane, which is seen in DLE or any other chronic dermatitis when there is a lot of fibrosis and other changes are happening. And to highlight the basement membrane, we do periodic acid shift stain, which will delineate the thickening or thinning of the basement membrane or even disruption. And if you do an EM, you will find these keratinous filaments within the ultrastructural examination with hemidesmosomes like this, these ones. You can see lamina lucida in the palms and soles, and then lamina densa. So lamina lucida is a just empty space. See here, this is an empty space running all around the keratinocytes, and these are your hemidesmosomes. Okay, and the keratin filaments and the anchoring filaments, they bind two keratinocytes. This is one keratinocyte. This is another keratinocyte. So the anchoring fibrils have a job to bind these two. So it's like breakup nahi hone dena hai. Okay, so they bind them together. Okay, so next to that is dermis. So as I told you, mainly it has two components, papillary dermis and reticular. This is a dermal papilla. You see a retipag here and a retipag here. These small projections into the epidermis, finger like projections, but they're small finger, like stout fingers. And in between this area, you have this papillary dermis, and deeper down, you will have reticular dermis. Reticular dermis usually will have more vasculature, and also you will have areas of, I'm sorry, part of the hair shaft seen within the reticular dermis along with thick collagen. You see here, a lot of thick collagen bundles are seen, and normally the collagen in the dermis parallel to the epidermis normally. Okay, it's in the same line as the epidermis, barring some conditions where it becomes perpendicular, or it becomes very thick, or it becomes collagenized, or some altered collagen like appearance, which I'll talk about later. So next structures which are seen in the dermis are the adnexal structures. So we all know you have eccrine glands with eccrine duct, you have apocrine gland, apocrine duct, and this is the pilosebaceous unit. You have a hair shaft here. This is the intraepidermal part of the hair shaft. I just showed you the acrosyringium. That's the part here. And the apocrine duct, it joins the sebaceous gland duct. Okay. And then it drains its secretions, whereas the eccrine duct opens directly into the skin surface. Fine. This is your sebaceous gland attached with the hair shaft and the hair here, right? And this is your apocrine gland, apocrine duct attaching to the hair shaft, the sebaceous gland. And this is your eccrine coils. The coils are more or less similar. The apocrine are a little more thicker. This is the hair follicle on a closer look. You see, this is the infundibulum part, the acrosyringium part, which we saw in the previous slide. The isthmic part, where you have the sebaceous glands attached, and then you have the hair bulb part. Here you will have a lot of keratin, vasculatures, and keratohyalin granules. So this is the portion which is dipping into the fat. You find the hair bulb at the junction of dermis and hypodermis, and here you will have traversing the arteries and nerves. So as I told in my first slide, that when you have to look at the vasculature and nerves, you have to look at the junction of dermis and hypodermis. So these are the fat cells. Fine. Okay. Now let's see how they look like histologically. So this is your sebaceous gland, the vacuolated cells. Periphery, you have basal layer, right? See here, this is normal sebaceous gland, and next to it is this pink bundles. These pink bundles are the erector pallid muscle, because the glands have to exude their secretions, so they need smooth muscle. They need muscle to contract and exude their secretions, sebum, or the apocrine secretions. So the muscles are in close association and relationship with the sebaceous gland. This is your hair follicle. Again, this is your hair bulb. See how hair bulb, it's like a cup shape, inverted cup shape structure. This is your hair bulb attached with the sebaceous gland. Closer look of the suprabulbar region of the hair bulb and the bulbar region. This is called as vellus hair, right? Vellus hairs are the softest hairs which the kids have, or you have the fine hairs on your cheek, not the men, but of course the females. They have the fine hairs on your face and cheek and all these. So these are like vellus hairs. You can pull them out easily. This is the cross section of the hair bulb. This is how the hair bulb looks like, and this is the cross section of the suprabulbar region. And this pink matrix, from here, the tumor arises pilometric soma, because it's a matrix here, lot of matrix. Okay. Now let's see the eccrine glands and ducts. Now glands are relatively larger. You see here, they have vacuolated cytoplasm. They'll be double layered. In skin, everything is double layered. All ducts and these glands are, right? But the ducts are relatively darker and smaller. The Glands are bigger. These are the eccrine ones, and this is the closer look of the duct. You see, again, this is a darker one, and this is the gland part. Okay. And sometimes you get to see this, the coiled appearance. So this is the opening of the eccrine ducts into the surface of the skin. Okay. So there will be a very globular coiled structure. Okay. And then, of course, apocrine glands, they will have these snouting. You see this undulated margins, irregular, like speed breakers, small bumps. Okay. These are apocrine glands. This is a higher magnification. Sometimes they show you decapitation. By decapitation, you means these secretions they shed off during in the lumen. And if you do PA stain, that is periodic acid substance, they'll be very strongly positive in the apocrine glands and the ducts. You see here, it's a little more blue than pink, but it should look like magenta colored. Okay, so they stain strongly with PA stain, positive. Then, of course, you have lobules of fat, which is the hypodermal region, and you see the collagen bundles which are running parallel to the epidermal surface. Okay. And of course, when you see the hypodermis and dermis junction, you will find lot of neurovascular bundles. You see the small nerve twig here, a small arteriole here. Now, nerve twigs are very important to examine, especially in cases of leprosy. You always have to comment on that. This is another dermal blood vessels and lymphatics here, capillaries. These are the lymphatics. These are small capillaries, a small sized artery, cutaneous fan. If you have to diagnose vasculitis in skin, you really need hypodermis to be in the biopsy. Otherwise, you cannot diagnose vasculitis. So the biopsy has to be deep enough, including the hypodermis. And of course, then this is again a nerve fiber. You see, wavy nuclei and surrounded by this perineurium, and this is the Pacinian corpuscle, so onion-like layering. Okay, these are much more commonly seen in the palms and soles because they are touch receptors. Fine. Okay. Now, the important thing is I was telling you in the beginning also, you should know the variations in the skin of various body parts. As I said that the stratum corneum will be thickened on palms and sole, followed by buttocks. The vascularity will be very high in the face and extremities, especially lower limbs. There'll be collagen variation from face to shin to tongue to back. And of course, if you get a mucosal biopsy, how do you identify this mucosal biopsy? You will not see any admixal structures, but you will see skeletal muscle fibers. There will be no granular layer, stratum corneum. However, whenever there is a mucosal injury, there will be retained nuclei in the epithelium. Parakeratosis will be there. Okay. And of course, you should know the melanocytes, which is highest in the genital area and lowest on the trunk area. Okay. And of course, the face of the nails. Now, a word about grossing and processing. Dr. Sridhar also talked about it. I would like to take your attention a little bit on that. So, for excision biopsies, you have to apply ink all over the margins and then you gross it. You take multiple sections, either in a 4-quadrant manner or multiple serial sections. For a punch biopsy, usually it is 4 to 6 millimeter. Our dermatologists are very nice, they give us a good nice punch. You bisect it or sometimes you trisect it. Okay, so you take 3 slices or 2 slices, especially in cases of alopecia where you need to have 2 separate sections, one for the transverse and one for the longitudinal section. Okay, if the biopsy punch is less than 3 millimeters, you embedded it toto. Don't bisect them and do not bisect the biopsy if the clinical diagnosis is a bullous lesion. Otherwise, you're going to rupture the bulla roof will be somewhere else and floor will be somewhere else. And in routine, we perform HME stain, which you're all aware of. Special stains have a very important role in skin. When you look at the melanin pigment or you look at the iron pigment or you have to delineate the fungi or you have to delineate amyloid, so you do all kinds of special stains, right? IHC in some cases, of course, especially metastasis, in adnexal tumors, it has limited role, but we do perform. IF is very important, especially in all bullous conditions, and elastic bond stain in all cases of vasculitis, and electron microscopic in cases of where you have to study the collagen or you have to look at the penis rectus, right? Which was seen in right? Penis rectus appearance, which can be only visible on electron microscopy. And of course, in this era, we cannot get away without the molecular testing. So there are certain diseases, especially bullous lesions and other genetic disorders, genodermatosis, where you need molecular testing to prove or disprove the mutational parameters. Okay. Now, this was the first part where we wanted to tell you where I wished you to know the normal histology and structures of the skin. Any queries till now, please, you may ask before I go into the pattern-based approach. Anybody? Ajay? No? Anybody else?
No.
So I hope I could give you the overview of all normal structures and you understood where are they located, how do they look like?
Yes.
Okay. Great. So next part of the talk is terminologies and pattern-based approach. So epidermis, the first layer is stratum corneum, and stratum corneum is just the keratin protein, right? When we say hyperkeratosis, so stratum corneum when it is thickened, right? It's called as hyperkeratosis. So it's a thickened cornified layer. And if you have 18 to 20 layers of corneocytes, that means it is thickened. But again, based on the body side. If it is palm and soles, it is not thickened. Okay. So that you have to see. And normally the stratum corneum is basket weave appearance. If it becomes compact, it is also abnormal. So you call it as compact hyperkeratosis or basket weave hyperkeratosis, depending on the type what it is showing. Okay. Now this is orthokeratosis. It is thickened stratum corneum, but it is maintaining the basket weave appearance, right? So when you say compact, this entire keratin will look like a thick, you can say compact eosinophilic material just over the epidermis. This is the case of keratoderma. You can see that there are vacuolar changes in the granular layer as well. Okay, and this is the compact hyperkeratosis. You see here, and there are some nuclei within the keratin. That means there is parakeratosis. Okay, so this is your basket weave hyperkeratosis, and this is your compact hyperkeratosis with parakeratosis. So retained nuclei in the cornified layer. Okay, commonly seen in all types of psoriasiform lesions, especially psoriasis and chronic dermatitis. Okay, so when we are talking of parakeratosis, the literal meaning of parakeratosis is scaling. So parakeratosis is incomplete keratinization because the proliferation is much more. So the nuclei which are to be shed off, they are not being shed off, they are retained in the keratin. So incomplete keratinization could be like this mount-like, right? And this is commonly seen in psoriasis. So see, regular prolongation of retapex and there's a mount-like hyperkeratosis with parakeratosis and some crust. You see some nuclear debris are also seen. So crust formation is also seen, and these are called as Monro's microabscesses. I'll come to that later. The other type of parakeratosis could be rounded parakeratosis, which is seen in all types of chronic dermatitis. You see, this is a small mount-like, which is also called as teapot-like or teapot-lid sign. Okay, and you see this collagen. There's a little bit of fibrosis and vascular proliferation in the dermis. So this is a sign of chronic dermatitis. And sometimes, if it is subacute stage, you may see this spongiosis in between. Okay, then other types could be dry and confluent and wet and focal. Right? Can you excuse me for a while? The phone is ringing. Just a sec. Sorry about that. Okay. So the next type of keratinization is dry and confluent. You see here, this is compact hyperkeratosis with parakeratosis and regular acanthosis. This happens in psoriasis vulgaris. And if you see here, there is absence of granular layer. Why absence of granular layer? Because there is no maturation. So there is rapid proliferation of epidermis. So all these nuclei are retained here and the granular layer is not being formed. So you should know that why granular layer is absent. And this, there is also suprapapillary thinning. Especially these areas will be showing absent granular layer. So this is a classical feature of psoriasis vulgaris: hyperkeratosis, parakeratosis, regular acanthosis, and absent granular layer. Now you know why there is absent granular layer, parakeratosis, and hyperkeratosis in psoriasis. Okay. Then you can have incomplete keratinization of wet focal with serum crust-like. You see here, very bad looking. This is usually happens in keratodermas. Very thick scaling, which can have serum and crust formation. You see here, neutrophils in a parakeratotic layer. And again, you have, but the acanthosis here is irregular. It's not regular. So some retapex are short, small, others are very long. So can you appreciate this? Hello? Yeah, can you appreciate this?
Yes, ma'am.
Irregular acanthosis with crust and parakeratosis. Okay. Then you can have checkerboard pattern or the certain parakeratosis. So if you see this biopsy, you again have regular acanthosis, but the parakeratotic column is alternate. You have parakeratosis here, normal compact keratin here, and then again parakeratosis. So it's like alternate compact keratin with parakeratosis. Usually seen in PRP, that is pityriasis rubra pilaris, or ILVEN, right? Then it is inflammatory. Lots of inflammation is also seen in the dermis. Okay. So next type is the coronoid lamina. This column of parakeratosis, which is angled towards the center of the lesion. You see here, this is the parakeratotic column, whereas the adjoining keratin is basket weave. That's normal. So this is seen in, again, ILVEN. Okay, linear epidermal nevi. So you see here, this is like cup and saucer appearance, which are kept one over the other. And then there will be loss of granular layer just beneath this parakeratotic column. You see here, the granular layer is preserved in this area, there is absent in this area where there is parakeratotic column. Then you have shoulder parakeratosis, very commonly seen in seborrheic keratosis. You see something like shoulder. So you have serum and crust over the epidermis, lot of plasma, nuclear debris, and they're shouldering the epidermis, and irregular acanthosis again, which is commonly seen in seborrheic keratosis. So now you know the types of incomplete keratinization. You can have mount-like, dry confluent, wet and focal, rounded, checkerboard, coronoid lamella, and shoulder parakeratosis. Okay. And the last but not the least, sandwich-like. So we are in a tropical country, so you should not forget that very commonly we get to see tinea infection. So if the keratin is very, very compact, no significant parakeratosis, I always ask for a PA stain to look for these tinea. So this is called as sandwich sign or spaghetti meatball sign. So the fungus will be spore form and some filamentous form will also be seen within the thickened keratin. So they are sandwiched between them. So that's why it's called as sandwich-like parakeratosis. Okay. Next pattern would be the spongiosis versus acantholysis. That is the epidermis within the epidermal spaces. If you see this first picture, you have a lot of pale areas in between. So this is because of the spongiosis. Spongiosis is the intracellular as well as intercellular edema, both type of edema. So there's increased spaces between these keratinocytes. Whereas if you see the next picture, the keratinocytes are getting discohesive. So this is due to acantholysis, right? And even in this picture, if you see the inside, these acantholytic cells are getting rounded up. Why? Because they have lost their desmosomes. So the spinous processes. If you remember the first slide, this layer is called as stratum spinosum because they have these spinous processes. So when there is blistering disorder, especially pemphigus, they lose their spinous processes and they become rounded. So that these are the acantholytic process of epidermal spaces causing blistering disorders. So this is the high part to show you intracellular as well as intercellular edema, which is happening in a case of spongiotic dermatitis, and a little bit of inflammation here, and a little bit of edema is seen in the dermis as well, just beneath the retapex, right here. So this is the case of spongiotic dermatitis, acute spongiotic dermatitis. Sometimes you have hydropic or ballooning degeneration, something like this. You see here, these are all looking like ballooned up cells, but they contain something. They contain this eosinophilic material. This is because of the herpes viral infection. So now next thing you have to look for is binucleation or multinucleation. If you see this, some of the cells are showing you binucleation and little larger nuclei. So this is a viral infection. It may not be herpes, it may be some other virus also. Then you can have reticular degeneration due to intracellular edema, causing keratinocyte swelling in the surrounding. So large spongiotic vesicles within the epidermis. So again, we qualify for spongiotic dermatitis with or without. So sometimes these viral infections can also produce small vesicles, especially the herpes. So then you should not mistake it with any vesiculobullous lesions. This is secondary to the viral infection. If you see here, some intrusions are seen within the keratinocytes. Okay. So if you see this picture, the next option would be the vacuolar degeneration of the basal layer, the next etiology. They look like something like this, string of pearls, right? See, these are water droplets. And if you see this basal layer, these are the melanocytes, but the basal layer are also showing you empty areas around them. This is called as vacuolar change in the basal layer. This happens in the interface dermatitis. All types of interface dermatitis will show you vacuolar change. And you should be wary that you should not misdiagnose the melanocytes with the basal cell vacuolization. That's very important. You see the cell character here and cell character here. Besides, you will get to see some degree of inflammation and edema in the papillary dermis in all cases of interface dermatitis. Okay. The next is abscesses and microabscesses. So you can have abscess in the stratum corneum, or you can have abscess in the stratum spinosum. If it is present in the stratum corneum, usually seen in psoriasis, which is also called as Munro's microabscesses. If it is happening in the stratum spinosum, they're called as Fogo's pustule. So it's just abscess means collection of neutrophils wherever, in dermis, epidermis, or in the stratum corneum. And because it's visible only microscopically, it's called as microabscesses. Okay. So when you talk about microabscesses, you cannot get away with these abscesses. So where are they located? These microabscesses. Which microabscesses? Anybody? Very good. And it is seen in classically seen in dermatitis herpetiformis, right? This is a florid case of dermatitis herpetiformis. However, you may get to see sometimes cases like this. Just have a subtle clue that some neutrophils are lying right here. So if you're not sure, always ask for more sections. And if you do immunofluorescence, you'll get granular IgA deposition in the papillary dermis. Cute. Okay, in the papillary tip. So that's a dermatitis herpetiformis. Next microabscess is the Pottier's microabscess. So Pottier, when we use the word Pottier's, it is associated with mycosis fungoides. But the misnomer is that it was described by Darrier and not Pottier's. Okay, so collection of atypical cells, these are the atypical cells in the stratum spinosum. That's called as Pottier's microabscess. And you see the moderately dense atypical lymphoid infiltrate with tagging of lymphoid cells along the entire epidermis, basal layer, and forming these collection of atypical cells within the epidermis. Now, mind you, if you see edema, then don't make a diagnosis of neoplasm. Neoplasm is usually associated with fibrosis. Minimal spongiosis may be there, but most of the time you will not see spongiosis in the epidermis in mycosis fungoides. And of course, you have to look at the cellular details of these cells, which will be atypical. Okay. What is pseudopottier's microabscess? When you talk about Pottier's microabscess, you should also know about the pseudopottier's collection of Langerhans cells. Sometimes look like pseudopottier's, and that is commonly seen in any inflammatory dermatosis, especially psoriasiform dermatitis and psoriasis. So see, there's a lot of spongiosis here, and you probably feel this nucleus is indentated and maybe atypical, but it is not atypical. This is the Langerhans cells. So it is showing you nuclear indentation and groove. Okay. Next one is the keratinocytes, individual keratinocytes. So they can show dyskeratosis, which is seen in Darrier's disease, like Copps, and grains. They can have owl-eye appearance, or they can have this grain-like appearance. You see, these are owl-eye appearance, which is seen in the granular layer. Multiple levels of split will be seen. No single level of spleen, and that will be intraepidermal. And these are shedded onto the epidermis. And as they go up, they lose their nuclei, and they're called as grains. When they are much more blue, they're called as corons. And when they, sorry about the spelling. And this is the grains when they are shedded outside. Okay. Apoptotic keratinocytes. Very commonly, you encounter these. Apoptotic keratinocytes are basically dyskeratotic keratinocytes, which can happen due to any inflammatory pathology, most commonly inflammatory pathology. So, how much is normal? So, 6 mm punch to humko milta nahi. Usually, we get to see 3 to 4 mm. Single apoptotic keratinocytes within an epidermis is ignored. However, with the exception of GVHD and drug induced. If you see even single, you have to report to that clinician because the treatment is different. Okay. In drug induced, the drug has to be stopped, and in GVHD, steroids have to be given. So, apoptotic keratinocytes look like this, eosinophilic structures, the nuclei shed off, or they will have pycnotic nucleus like this. So, if they are present in the epidermis, they're called as apoptotic keratinocytes. If they're present in the dermis like this, they're called as civet bodies. And civet bodies are seen in lichen planus. Okay. Yeah, this is it. They can be satellite cell necrosis in the keratinocytes, and sometimes you may say whether it is apoptotic keratinocyte or satellite cell necrosis. So you have to see the surrounding milieu. If the cells are atypical, like in this case, you have atypical cell infiltrate. So this is happening in a case of mycosis fungoides. So that can also cause necrotic keratinocytes or individual keratinocyte necrosis. Okay. So when we talk about individual keratinocytes, do not forget the inclusion. So what is this berry? Which berry is this? Red berries, right? And this is a picture of, if anybody has seen it, it's a classical molluscum contagiosum. So you see that invagination, prominent red granules, red inclusions of the virus. See here, something like red berries. So this is molluscum contagiosum, and this is Palmoplantar myrmecia. You see prominent keratohyaline granules and these eosinophilic inclusions of the virus with irregular acanthosis and hyperkeratosis. So this is myrmecia, irregular proliferation of the epidermis. So that's how the viral inclusion should be looked for. So do not mistake these as some foreign bodies. So sometimes people say we do not know. So these are viral inclusions. Okay. So after epidermal thickness, we come to the thinning of epidermis, whether it's atrophy or it is effacement. So when we say atrophy, the stratum spinosum layers reduced to less than 5, right? Normally it is 5 to 7. When it is called atrophy, it reduces to less than 5. You see here, this is atrophy. And commonly we encounter a lot of leprosy cases where we will have epidermal atrophy. This is a case of collagen homogenization. You see here, the collagen is very, very thickened. There is no interstitial space in between. If you compare the collagen beneath it, you have some spaces in the collagen, whereas this is much more thickened. This is a case of lichen sclerosis atrophicus, where you have atrophic epidermis, collagenized collagen, homogenized collagen, bordered by inflammation, and then normal collagen. Whereas in cases of melanoma also you can have thinning of epidermis. You see here. Or even in lymphomas, sometimes you can have atrophy. Lentigo maligna also can show you atrophic change. And a lot of melanin pigment is seen along with the melanoma cells. Acanthosis, when you say epidermal hyperplasia with only increase in stratum spinosum, more than 7 layers. Now, this is how it is called as acantho, because these have spinous processes. Acantho, the literal meaning is spinous or prickly appearance. And they can be seen in all proliferation of the epidermis. May be benign or it could be malignant. So, in benign condition, seborrheic keratosis, or in malignant condition, Bowman's disease. But in Bowman's disease, you'll not see this kind of appearance. There'll be wind blow appearance, haywire appearance. So, if you stand in the wind, your hairs have no direction to flow. They'll flow in all directions. So, something like that you'll see in the Bowman's disease. There will be wind blow appearance. Okay. So we talked about thickening of epidermis, which could be psoriasiform, pseudoepitheliomatous hyperplasia, papillomatosis, or verrucous. Verrucous is commonly seen in any viral infection, including papillomatosis. Pseudoepitheliomatous can be seen when there is any dermal pathology or just as a reaction. Or psoriasiform, regular acanthosis is usually seen in psoriasis or any chronic dermatitis. Okay. And if you see suprapapillary thinning, absent granular layer, parakeratosis, it's classical for psoriasis. So how do we differentiate psoriasiform hyperplasia from pseudoepitheliomatous hyperplasia? When you talk of psoriasiform hyperplasia, it's very, very regular. You see here, very, very regular. Whereas when you see pseudoepitheliomatous hyperplasia, there'll be a lot of papillomatosis also seen. So these transversely cut structures are the papillomatous structures. Okay, you see this is very regular. No significant parakeratosis or hyperkeratosis is seen in pseudoepitheliomatous hyperplasia, and that's a reaction to whatever happens in the dermis, similar to seen in metastatic carcinomas or some neoplastic pathology seen in the dermis. So papillomatosis versus verrucous hyperplasia. Now this is a verrucous hyperplasia where you have a lot of thick keratin along with papillomatosis. See, these are the dermal papillae and regular acanthosis. So these are seen in again, and they're pointing towards the center. See here, seen in viral etiologies. Okay, whereas in papillomatosis, again you can see these are the dermal papillae which are very, very elongated. So they're giving like church spire appearance, which is seen in acanthosis nigricans. Okay. Now, when I talk about Pottier's microabscesses and Munro's microabscesses, I also talked about mycosis fungoides. When we say exocytosis, it's an active transmission or transfer of these inflammatory cells into the epidermis, accompanied with spongiosis. That is exocytosis. When we say epidermotropism, that means it's a passive infiltration of these lymphoid cells into the epidermis without inducing edema, intracellular or intercellular, right? So you use these terms carefully. Exocytosis is much more commonly seen in skin compared to epidermotropism. Before you say epidermotropism, you should be sure that you are dealing with a case of mycosis fungoides. Okay. So the next component will be dermis. So in dermis, most commonly we encounter leprosy cases. And when we encounter leprosy cases, you have to look for the gren zone. And gren zone is what is it? An uninvolved papillary dermis which separates the epidermis from the dermis. So it's derived from a German word which means literally border. Okay. Sometimes you can have even in lymphomas or in any leukemia cutis or any other infectious disorder also you can have gren zone. So but in mycosis fungoides, T cell lymphomas will not show you gren zone. B cell lymphomas will show you gren zone. Okay. This is a case of treated case of leprosy which is going on to the type 1 reaction. So upgradation. So no granulomas, but you have lots of lymphoid infiltrates. So it's a BT type of leprosy. Okay. And these are the list of cases with gren zone. Next thing would be pigment incontinence. Very, very commonly seen. I told you in the beginning that a patient of cutaneous amyloidosis will have lot of pigment incontinence and nothing else in the skin biopsy. This is because the lesions are very itchy. So the patient is scratching. So melanin gets exuded, you will have subtle inflammation. And sometimes you may get to see atrophy of the leaf defects. Okay. So if you have increased melanin in the dermis, that's also abnormal. And you will get collection of melanophages. Many times it is associated with vacuolar degeneration of the basal layer because you have melanocytes here also. So which can also happen in any case of interface dermatitis. When we say interface means interface of the epidermis and the dermis. This is your basement membrane. You cannot delineate the basement membrane at the edge of the biopsy. That means there is an interface dermatitis leading on to melanin incontinence and collection of melanophages. Next thing would be the connective tissue, that is the collagen. Either it can be decreased or it can be increased. Increased dermal collagen is seen in scleroderma. The beauty of the scleroderma biopsy is that it will have a very sharp margins, sharp borders. It's called as cookie cutter sign. So when you put in a pore for the biopsy, it will give you very sharp margins. You can draw a straight line with the scale from here, whereas normally it will not happen. So that's a classical example of scleroderma, and you might have epidermal atrophy in these cases. Okay. This is solar elastosis. When the biopsy is from the sun exposed area, it gives a bluish hue. You see a lot of solar elastosis. And of course, you can have altered or necrotic collagen, and they are palisaded by these histocytes. So they can have red granulomas or you can have blue granulomas. Red granulomas, when it is more fibrinoid necrosis, you see this is much more pink, bordered by histocytes. And red granulomas are seen in rheumatoid nodules, right? Or necrobacillus lipoidica. Whereas the blue granulomas are seen in granuloma annulare, where you have this color in the collagen. This is much more pink, whereas this is much more blue, right? Again, bordered by the histocytes. Sometimes you may see giant cells. So this is seen in granuloma annulare. Okay. And occasionally, I've not seen very many cases of Wells syndrome. You may see these fire flare appearance because of degranulation of the eosinophils. These are called as flame figures. So lots of eosinophilic infiltrate, but don't mistake them for red granulomas. Look at the surrounding infiltrate. So lots of eosinophils. So this is the case of Wells syndrome. Okay, so because of deposition of eosinophilic granules around them. And of course, don't forget giant cells. Very common trend, no? In skin, we commonly encounter them. But look into the giant cells. What are they containing? Are they having fomic cytoplasm? Or are they containing some structures like this asteroid body? Or are they containing any foreign structures like this? Or they are containing these elastic fibers like elastolytic giant cell granulomas? Or containing these calcific bodies like you see in sarcoid? Asteroid bodies also can be seen in sarcoid. And of course, cholesterol clefts like this. And do not forget cutaneous fungal infection. Now, here I would like to add one thing. When you see the cutaneous function, there will be a lot of epidermal reaction as well. You'll see a lot of irregular acanthosis and moderately dense inflammation rich in plasma cells and necrotizing granulomas. When you say necrotizing granulomas, you'll see neutrophils in the center, right? Next would be vascular abnormalities. You see a lot of RBC extravasation. So when you see RBC extravasation,
hello
you might
ma'am,
be alert.
can you
Yes?
put your laptop in charging mode?
Oh, yeah.
Yeah, your battery is down. No?
I think usually Apple works fine, but I'll do that.
Yeah, thanks ma'am.
So if you see the picture, you can see a lot of RBC extravasation. So a lot of red structures can be seen. Can you all see that?
Yes, ma'am.
Yeah. So when you have this, so there are 3-4 differential diagnoses. So any disease in skin, which is the name rubra, that can show you extravasation of RBCs. Okay. So you should know that. And rubra is there. But depending on the stage of the biopsy, if the biopsy is done in the later stages, you may not see RBC extravasation. Okay. Pityriasis rubra pilaris or any other skin condition which will have rubra in them. So, but in addition to that, you should also look for any vasculitic changes. You see, these are the capillaries. Lot of RBCs around, lot of nuclear debris. Now these are neither neutrophils nor lymphoid cells. So that means there is fibrinoid necrosis of the capillary wall. Lot of inflammation, karyorrhexis is happening, leukocytosis. So these are classical case of vasculitis. So you have 5 cardinal signs of vasculitis. You will have fibrinoid necrosis of the wall, karyorrhexis, RBC extravasation, endothelial swelling, or fibrin thrombi. And out of these 5 features, 2 must be present to call it as vasculitis. And the most important feature would be fibrinoid necrosis and fibrin thrombi. Okay, along with karyorrhexis. Whereas if you find something like this, you see this. These are pink things which are just occupying the lumen of the vessel. So these are only fibrin thrombi. There is no itis. So this happens in thrombosis or vasculopathy. There is no itis. There is only vasculopathy. So you should know about these terminologies. Otherwise, you will mistake this for vasculitis. Clinically, the presentation is different and the treatment is also different. Okay. Then of course, don't forget the paniculum. So you can have a lobular paniculitis, you can have a septal paniculitis, or you can have a mixed paniculitis. And whenever you see paniculitis, always look at the vessels. Always. Look for any giant cells, look for any venulitis, look for any arteritis. Because most of the times you have to, when you're not able to pinpoint etiology, you say paniculitis, septalobular or septal with or without vasculitis. That's how you put the bottom line. And sometimes the epidermis is normal, but you see lots of lobular paniculitis is seen here in the lobar. This can be seen in either DLE, that is lupus profundus, or subcutaneous paniculitis like T cell lymphoma, SPTCL, right? So these are the cases where you need a lot of paniculum in your biopsy. So if the clinician has not done a good biopsy, do not hesitate in asking for a repeat biopsy in such cases. Okay. So as I said, in the subcutaneous vein, look for these veins. They're surrounded by this histiocytic collection and occasional giant cell. And these are described in erythema nodosum, called as Misch's granulomas. Okay. And if you see vasculitis or venulitis, they are seen in erythema induratum, also known as nodular vasculitis. Though the etiology remains the same for both, and the treatment also remains the same. It's a hypersensitive response to the tubercular antigen. But in one, you will have this kind of Misch's granulomas. In another, you will have nodular vasculitis. Okay. Then, as I was just talking about the SPTCL, subcutaneous paniculitis like lymphoma, you see the rimming of atypical cells around the adipocytes. Lot of nuclear debris. And whenever you have nuclear debris, so it's party time for the histocytes, right? Lot of histocytes will come and envelop these nuclear debris and atypical cells, and they produce that beanbag appearance. So that you have to look for it. So rimming of adipocytes with atypical cells, nuclear debris, and beanbag appearance. Okay, so this is seen in SPTCL. And sometimes we do not know what the exact etiology could be. So we just leave it as like descriptive terms like saponification with nuclear dust and ghost cells. We do not know the clinical findings of the patient. As I said in the beginning, many times the dermatologists do not give us the clinical history. So we leave it as a saponification and fat necrosis in the description and give a descriptive report. Very commonly seen in pancreatic paniculitis. Okay. And as I told you about hyalinization of the fat also. After lupus profundus, the septum will get sclerotic. It becomes lipodermosclerosis. So if you do not know the history, but you just leave it as lipodermosclerosis. Otherwise, you just put it as there is lupus paniculitis. There is paniculitis with lipodermosclerosis. Okay. And of course, do not forget the granulomas in the skin. We are in a tropical country. If you see granulomas in skin, please, again and again, do all the special stains to rule out any etiology, infective etiology. First, rule out infective etiology. After that, you look for any conationolytic granuloma, foreign body type, or xanthogranulomatous. Right? And in fungal infection, usually it is a suppurative granuloma. You see here, this is a palisaded granuloma, this is a tuberculous granuloma, and this is a suppurative granuloma. You have neutrophils in the center, surrounded by lymphoid cells and histiocytes. Okay. Asteroid body is not specific for sarcoid, but I guess if you see it, it favors. Asteroid body can be seen in sporotrichosis as well. So you should be careful. You have to see the entire milieu in the biopsy. Okay. And what type of granuloma is this? Anybody? What type of granuloma? So there is epidermal thinning here. There is no brain zone here. Lot of inflammation, pandermal inflammation, reaching up to the fat, and you have these granulomas. So what type of granuloma in the hyper? Necrotic or non-necrotic? First thing.
Non-necrotic.
Very good. It's a tuberculoid granuloma, and you can also see a calcified area here. Lots of lymphoid cells, non-necrotic, and some giant cells. So this was when you're not sure what is the etiology, you just leave it as a granulomatous dermatitis, and whatever you're favoring, you put that into your remark. Favoring tuberculosis, or favoring leprosy, or favoring fungal, whatever. Right? Okay. So when we have to interpret the skin biopsy, it's always pattern based. So first is tissue reaction pattern, which could be epidermal, dermal, or involving the paniculum, and then the pattern of inflammation. Where is it located, and what is the type of inflammation? It's neutrophilic, eosinophilic, lymphocytic, plasmacytic, or just histiocytic. Based on that, you report it, and these are the major patterns. If you're not able to pinpoint the etiology, you just leave it as a psoriasis-form dermatitis. Favoring this, whatever you feel. Spongotic dermatitis, lichenoid dermatitis, and usually in lichenoid dermatitis, you will get interface dermatitis due to basal cell damage, and lot of lichenoid infiltrate, a band-like infiltrate in the dermis. Vesiculobullous, usually you will be able to identify however immunofluorescence is necessary to categorize the type of vesiculobullous lesion. Granulomatous, you can only leave it as a granulomatous dermatitis, advising the further molecular workup or special stains. And of course, vasculopathic versus vasculitis when you see changes in the vessels. Okay, so that's all, folks, for today. I think I've given you the overview and brief about the patterns and normal histology of the skin. If you still find difficulty, you can always refer the case to me through telepathology, or you can have join dermatopathology fellowship in PGI. Thank you so much for your patience and time. Yeah. Okay. Any questions or any inputs, Dr. Sridhar?
Yeah, I think walk us through the basic patterns of skin lesions, especially the normal pathology of the skin, and out very succinctly the various reaction patterns. I'm sure these are the pathology residents. I see that there are a few questions.
Yeah, please.
Taking off.
Yeah. Okay. Not necrotic. I didn't understand that. What is not necrotic?
No, sir.
How does the pathology center? That's the first question. So we can either do it by email or we do it through eSanjeevani, right? If you are in a government hospital, or by email. So the email is telepathology@pgimr@gmail.com. Can you post the email? Okay, I'll share the email with Dr. Sumit. Textbook for dermatopathology. The best textbook I found is Whedon. Don't read Weavers. Read Mackey or Whedon. Mackey is a thick book, 2 volumes, so read Whedon. Best book.
Whedon.
Whedon. W-E-E-D-E-N. Yeah, Whedon. Mackey or Whedon. Don't read. I hope I tried to make the slides very simple and easy because many of them have not seen the skin biopsies in abundance, so that they know, okay, when they see this, what to think of and what to report. At least they can write the pattern, if not the diagnosis. So, Atray? Bhavna?
Yes.
Any questions? Will erythema nodosum or induratum present as large nodules in the leg? Yes, of course. So there are 5 differential. Painful nodular lesion in the extremities. I always ask my residents. Erythema nodosum, induratum, SPTCL, and vasculitic lesions, right? Sometimes. So vasculitic lesions are painless. They're not really painful. But these are, and ANL, of course, don't forget ANL. Okay. So these will usually present in extremities, legs, painful nodular erythematous lesions. Okay. These are the 5 differentials you should remember. And nodosum will not show you vasculitis. Induratum will show you venulitis, not even vasculitis, venulitis. That's why the term is nodular vasculitis. Vicious granulomas are seen in nodosum, which are not seen in induratum. Okay. Yeah, sure.
Ma'am, in the chat box, I think sometime back there was a question like when we were discussing about paniculitis, like what is paniculitis? Like, can we just have a brief view of that again, ma'am?
So, see, it's itis, right? Itis means inflammation. So you have 2 things, no? There are lobules of fat which are separated by septae. So either the entire lobule of the fat is involved, which is called as lobular, or the septae are involved, which is called septate. But most of the time, you will have septolobular paniculitis. Most of the times, in my experience, 60 to 70% of the time, you'll get mixed pattern. Septal alone or lobular alone is less common, very less common, right?
Ma'am, I have another question, ma'am.
I'm sorry to interrupt you. Dr.
Can I go ahead, sir?
One sec. Has Dr. Sridhar shown his cases?
No,
I haven't, sir. But what I request is let the question and I can answer them.
So internet connection is
yes.
interrupted.
Sridhar, your voice is breaking.
Yeah.
Okay, sir. I'm the question.
Anyway, your voice is breaking, Sridhar. You'll have to. Yeah, network.
I'll change my network.
Anyway, you carry on with the Uma. Aparna, please carry on.
Yeah, please.
Ma'am, I have a question. When you had mentioned about cutaneous amyloidosis, you mentioned that the patient or in the biopsy we may not see any significant findings, like we may just find only pigment incontinence as such, or chronic, just by chronic dermatitis. So in such cases, and clinically suspect amyloidosis.
See, it's not even chronic dermatitis. You will only see subtle changes. Mostly, you will see increased number of melanophages and melanocondinence because the lesions are itchy. So that's your clue. And then you have to pick up your phone call and ask your dermatologist because clinically the patient has like mosaic-like pattern, alternate dark light areas, and they're very troublesome because it's all the time scratchy, right? So biopsy-wise, you may not find. You're lucky if you find. Nodular amyloidosis, you won't find. Sorry?
Sorry, so how do we sign off such cases, ma'am?
So descriptive. So you just describe your findings and you can suggest that no specific pathology is seen and whatever you want to wish to say, whether there is any parakeratosis or there is any paniculitis or vasculitis or whatever, no granulomas or neoplastic, and you leave it as descriptive. And if you can call your dermatologist, that's the best thing. If you cannot, then you just write in the bottom advisory note remarks, kindly collate clinically and discuss. They usually come back to us. Dermatologists are nice people.
Yes, ma'am. Thank you, ma'am.
Yeah. Okay.
So we have one more question. What is the difference between hyperkeratosis and orthokeratosis?
So I said no, orthokeratosis is basket weave. You've seen a basket, no? So they're not compact. So when you say compact parakeratosis or keratin, the spaces between the keratin is lost. Whereas in orthokeratosis, that's a normal keratin. You have a basket weave appearance. Or this is normal. Now orthokeratosis can also be hyperkeratosis, but it may not be compact. So that's a different thing. So orthokeratotic hyperkeratosis, that's one term, or compact hyperkeratosis, that's another term. Okay.
Hi, Shidhar, present your screen. Just share your screen, Shidhar. Shidhar can't hear us.
I think he has an interrupted connection.
Yeah, no, it was okay in the beginning, but it's okay. I think you carry on with Dr. Uma, you want to say something? Any final comments to the students?
So
there is one in the chat.
Yeah, please.
How to differentiate between LPP versus EDP?
Okay, so LPP has usually atrophic epidermis with vacuolar degeneration and lot of melanin continence. Again, they are itchy lesions, right? And there is interface dermatitis. So because of interface dermatitis, you will have lot of melanin continence accompanied by inflammation depending on what stage you are biopsying the lesion. Whereas in EDP, there will be increased pigmentation and perivascular inflammation. It's not going to be lichenoid infiltrate. The pigmentation clinically also is different. In LPP, it is ashy dermatosis, right? The ash colored pigment. Whereas in EDP, it is more so darker color because of the melanin. And you have very tightly packed lymphoid infiltrate around the vessels. Unlike the lichenoid infiltrate in LPP. We're talking of lichen, this thing, planopilaris, or we're talking of lichen planopigmentosus? There are two LPPs.
Yeah.
If you're talking about pilaris, it will be more around the pilar region, the hair shaft. There's a question significance of follicular and teratotic plugging by skin biopsy. So if it's a case of lupus, DLE, then it is significant. Otherwise, you can get follicular plugging in many conditions. It's not specific. It's a sensitive feature, but it's not a specific feature. Like in PRP, you'll get follicular plugging. In DLE, you'll get follicular plugging. Sometimes in tinea infections also, you can get follicular plugging. In scabies, you can get follicular plugging. So there are many diseases where you can get follicular plugging. Any other question?
I think the LPP was reported with lichen planus pigmentosis. So.
Pigmentosis, yeah. So I got it. That's why I said ashy dermatosis. So in that, the clinical picture is also different. Lichenoid, does it mean thick? No, lichenoid means a band-like infiltrate just beneath the rete apex. So upper dermal involvement, papillary dermal involvement. Okay. Whereas when you see DLE, it is a pan-dermal involvement. So entire dermis is involved.
Hi. There are no more questions now? Any more questions?
No, sir. That's it, sir.
That's fine. Any final comments for students you want to like to say?
Vacuolar degeneration from melanocytes. So again, that question is come. So as I said, melanocytes will be dark cells and they'll be surrounded by halo. When you talk about vacuolar degeneration, there'll be irregular spaces around the epithelial cell, that is the basal cells. Right? And vacuolar degeneration is not one cell, no? It's in continuation. Whereas melanocyte is one cell among the basal cells. So what I have to tell the resident is, neutrophilic exocytosis, no, we don't use that term. Neutrophilic exocytosis is not used. So what I have to tell to the residents is that skin, when you approach in a specific manner, top to bottom, you'll reach to some conclusion in pattern-based approach. You may not be able to pinpoint the exact etiology, but at least you can give a pattern-based diagnosis. And if you give a pattern-based diagnosis, at least your clinician knows what category he or she is dealing with. Whether it is lichenoid, it is psoriasiform, it is vesiculobullous, or it is vasculopathic, or it is vasculitis, or it is granulomatous, right? So if you remember these 6-7 patterns, if you give a pattern-based diagnosis also, that helps the clinician at least in 50-60% cases. And another 40% you have to do for CPC. So you have to do a clinical pathological correlation. In skin, you cannot get away without it. Okay, that's what I want to give as a bottom line. So 40% of the cases in skin biopsies require CPC and closed discussion. Okay, so even if you are not very well connected to a dermatologist, put a remark there. Kindly discuss, and possibilities favored are 1, 2. Always give references, no issues. Okay. Yeah. So anything else? See, this is just an overview. Skin is huge. I said no, it's the largest organ. So if you start taking one chapter, you can take the entire CME can be on one chapter. And I have to thank Dr. Sumit for giving this platform to share my experience.
Thanks to you, Uma.
5 points in vasculitis. So who's Galaxy? I don't know. Anyway, so 5 points. Most important is fibrinoid necrosis, leukocytoclasia, fibrin thrombi, endothelial swelling, and RBC extravasation. And out of these 5, 2 has to be seen. 2 most important are leukocytoclasia and fibrinoid necrosis, infiltration of the inflammation into the vessel wall. These are the most important. If you don't see them, don't report. No, there's no term called lymphocytic vasculitis. Don't I discourage that term. It can be seen in thousands of skin conditions. So don't use that word lymphocytic vasculitis. Okay.
So I think thank you very much for
thank you.